Welcome back, future doctors. Today we're talking about actinic keratosis, a premalignant skin lesion you must not miss. It occurs most often on sun-exposed areas. In men, that's the head, neck, forearms, and dorsal hands. In women, the same areas plus the legs are common sites. Clinically, these lesions appear as poorly circumscribed, erythematous macules, papules, or plaques, a few millimeters to a centimeter in size. They have an adherent, sandpaper-like scale and sometimes form a hypertrophic verrucous surface called a cutaneous horn. Some lesions can be tender or even hyperpigmented. Diagnosis is usually clinical, but if there's any doubt, a biopsy is done. The differential includes Bowen's disease, squamous cell carcinoma, basal cell carcinoma, and seborrheic keratosis. Management begins with prevention. Sun protection with sunscreens, protective clothing, behavior modification, smoking cessation, and even a low-fat diet to reduce lesion risk. For treatment, the most common methods are liquid nitrogen cryotherapy, curettage with desiccation, or topical agents like 5-fluorouracil, imiquimod, diclofenac, or tretinoin. Photodynamic therapy is another option. Follow-up is key. Re-examine the patient 6 to 8 weeks after therapy, then every 6 to 12 months to monitor for response and new lesions. Remember this exam pearl. Actinic keratosis is premalignant. Around 10% of untreated lesions can progress to squamous cell carcinoma within 10 years. So always recognize, treat, and follow up these lesions carefully.